You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 28th, 2025. This week, we'll talk about stopping anticoagulation after AF ablation, the core problem with paradoxes like the smoker's paradox, CTO PCI, and an ACC and ERA preview. The first topic today is oral anticoagulation after AF ablation. A listener left me a comment and suggested I look at a study about stopping oral anticoagulation after a successful AF ablation. I had passed on the study earlier, but I have thought more about it and I will make some brief remarks today. Now, the reason to mention the issue of anticoagulation after AF ablation is that one of the most difficult questions in all of EP. Now, think about it. We use anticoagulation when patients have AFib and risk factors, and there's hugely strong evidence to back this decision. Then we do ablation, and then the patient no longer has AFib. Or, more precisely, they no longer have AF symptoms. Knowing whether post-ablation patients have AFib is another matter because a not small number of patients still have AFib after ablation, but they no longer feel their AFib. And it's weird, but ablation can reduce or eliminate symptoms from AFib. Now, the advent of watches and mobile ECG devices has lessened the problem of detecting AFib, but still, the correlation of AF episodes and symptoms after ablation is imperfect. Yet, the oral anticoagulation decision after ablation is not as simple as just the presence or absence of AFib, because when you ablate in the left atrium, especially when you do more than just PVI, there is the possibility of creating a prothrombotic state from, say, LA scar from all the ablation. The recommendations now for anticoagulation after ablation is to use the CHA2DS2-VASc score. If a patient was eligible for anticoagulation before the procedure, then you should continue the anticoagulation post-procedure. But that's really an expert opinion type level of evidence. There's no data. And it seems crazy to continue anticoagulation for years, decades even, in someone you've ablated and there's never, ever any AFib. Well, JAMA Network Open has published an attempt at creating some evidence to inform this decision. Japanese authors performed an observational retrospective cohort study of 1,800 patients who had no AFib after an ablation, and this was from a single center. The authors made two simple groups, those who had anticoagulation continued and those who had it stopped. Now, of course, stopping was up to the discretion of a clinician. AFib was excluded in the study by Holter monitors and intermittent ECGs, not loop monitors, so that's clearly a weakness. The primary outcomes that they were interested in were what we're all interested in: stroke, systemic embolism, the thrombotic side, and major bleeding. As it turned out in their cohort, about half had anticoagulation continued and the other half had it stopped. And as you'd expect, there were substantial differences in baseline characteristics. The anticoagulation stopping group were younger, they had more paroxysmal AFib versus persistent, they had more symptoms and a lower CHA2DS2-VASc, for instance. And conversely, the oral anticoagulation continuation group had considerably higher rates of warfarin use, antiplatelet use, and use of heart failure medicines. Now, you know what has to happen next. The authors had to do adjustments to try and balance these baseline differences. And they used an inverse probability of treatment weighting technique, and they also did propensity matching as well, and I'll talk more on those techniques and how they factor in a little later. And the authors found that after adjustment, the anticoagulation discontinuation group had a significantly higher incidence of thromboembolism and lower rate of major bleeding. Now, the incidence rates were very low, which is the problem with studying this question, by the way. For stroke events, it was 0.86 events per 100 person years in the discontinued group versus 0.37 events per 100 patient years in the continuation group, and that difference had a p-value of 0.04. Now, it was the opposite for major bleeding. In the anticoagulation continuation versus discontinuation arm, it was 0.65 versus 0.1, events per 100 person years. And that p-value was stronger at less than 0.001. And then they did something interesting and looked at subgroups. After adjustment, there was a very significant interaction in the rate of clotting events between the symptomatic and asymptomatic AF. In patients with symptomatic AF, the hazard ratio for discontinuation was 0.64, but wide confidence intervals, so basically non-informative. However, the hazard ratio for discontinuation in patients with asymptomatic AF was 6x, with confidence intervals that went from 2.5 to 15, and that p-interaction was very low. An interaction p-wave was also less than 0.05 for two other subgroups, those with LVEF that was greater than 60 and less than 60, and those with LA dilatation and no LA dilatation. And finally, another interesting observation was that when they used propensity matching, which is another way to match baseline characteristics, in 1,100 of the 1,800 patients, they found no difference in thromboembolic events between the continuation and discontinuation groups. They did find lower rates of major bleeding in the discontinuation arm when they used propensity score matching. They also found an interaction in propensity matching for symptomatic versus asymptomatic AF, LVEF, and LA dilatation. The authors made the normal conclusions, and they restated the associations and made note of the notable subgroups. They also said that they await future RCTs. Now, I'm glad that Dr. Dennis Hart, a commenter, pushed me to look more closely at the study. I think the team of authors did a nice job, and I actually learned some things. One is that the rate of thromboembolic events in patients with purported successful AF ablation is very low. Here, it was less than 1 per 100 person years, essentially less than 1% per year, no matter the decision. Now, the mean CHADS-VASc score in this study was very low, 1.45. And these were not obese patients. A BMI, it was 24 on average. You don't see that in U.S. or Australian or European AFib studies. Less than half of this cohort even had hypertension, and only 10% had diabetes. Now, while the p-value in the IPTW group made significance for oral anticoagulation continuation, it did not differ when you used propensity matching. And even if it did, the absolute difference was very tiny, less than 1%. So lesson number one, I think, from this study is that in relatively low-risk patients without AFib after an ablation, the rates of thromboembolism are very low, no matter the decision on anticoagulation. Now, lesson two, of course, is that when you stop an anticoagulant, rates of major bleeding decline, and that's seen in like every study. So we can move to lesson three, and that's in the subgroup of asymptomatic AFib, or those with an impaired EF or large left atrium, there may be more risk with oral anticoagulation discontinuation. Now, due to the non-random nature of these comparisons, despite the matching that they did, there's no way to make any clinical decisions based on this data. Obviously, the baseline differences in these two groups were massive, and confounding biases are surely there, and clinicians made the decision, not randomization. But these three lessons, I think, stand out, and it makes me worry about the all-important upcoming OCEAN trial. The OCEAN trial is scheduled to finish this year. And OCEAN is going to be huge. It's an RCT comparing 15 milligrams of rivaroxaban versus aspirin in patients with a successful AF ablation, and patients will be randomized to one of the two groups. So, as you know, randomization balances known and unknown characteristics. The primary outcome of this OCEAN trial is going to be a composite of stroke, systemic embolism, or covert stroke detected on MRI. Bleeding will be a secondary outcome. And on the surface, having an RCT for this question is going to be great. And I say good on Dr. Atul Verma and colleagues for doing this important trial. The challenge, I think, will come in its interpretation. They estimate an annual primary outcome event of 3.5%. And they're powering the trial for a 40% relative risk reduction with rivaroxaban. Now, this observational study, with its event rates well below 1%, makes me worry that OCEAN will be underpowered for its primary outcome. And if that happens, we'll have a non-informative primary outcome, along with higher rates of major bleeding in the rivaroxaban arm. Though That bleeding issue is not 100% guaranteed because recall that apixaban and aspirin had fairly similar rates of bleeding in the Averroes trial. Now, one hope is that OCEAN will enroll much sicker patients in this Japanese observational study. Another hope is that we might see subgroup effects in OCEAN, like we did in this paper. But still, we're talking about patients who've had successful AF ablation. They're going to likely have a very low stroke event rates. So the confusion could come in people saying, oh, well, in OCEAN there was no significant difference in stroke and there was more bleeding, so let's stop the oral anticoagulation after ablation. Now, I think that would be an incorrect interpretation if the confidence intervals of the primary outcome are very wide. In sum, I'm quite surprised about how much I learned from this observational non-random comparison study. All right, next topic is the smoking paradox. JACC Intervention Journal has a paper, first author Antonio Presch, looking at smoking status and 10-year outcomes after DES stent using something called decade cooperation, where an individual patient data from 5 trials were pooled. Now, these were all trials that were testing different stents or different stent techniques. The point of this paper was to look at outcomes based on the baseline smoking status. And you might ask, why do such a thing? Because we already know smoking is one of the most important risks for poor outcomes. Without stents, with stents, doesn't matter. And we don't need more data. Well, little did I know that the cardiovascular literature is full of papers purporting a so-called smoker's paradox, first reported in 1968 and perpetuated by numerous observational studies that compare outcomes of smokers and non-smokers who present with MI, for instance. One such paradox paper is written by Gupta et al. From the Journal of the American Heart Association in 2016, which I will link to. They used an inpatient sample database to look at nearly 1 million patients who presented with STEMI and had PCI. And then they compared outcomes based on smoking status, and lo and behold, smokers had a 68% lower inpatient mortality than non-smokers. After adjustment, it was still 40% better than non-smokers. The title of their paper was, quote, "The Smoker's Paradox in Patients with STEMI Undergoing PCI." Now, I could cite oodles of these sorts of papers. There are many more. There are also similar papers for obesity and heart failure, which gets called the obesity paradox. Let's come back later to why this is utterly wrong. For now, let's go to the decade cooperation meta-review of 5 trials that have 10-year follow-up to see what smoking baseline status reveals. Now, Presch et al. Report that after adjustment, smoking was bad. They had a 45% higher risk of death, 59% higher risk of CV death, a 60% higher rate of MI, and a doubling of the risk of stent thrombosis in baseline smokers. All of this despite the fact that patients in the smoking group were 10 years younger and presented more often with less complex disease at the time of the primary PCI. Now, my comments are that these results are obvious. Everyone knows smoking is bad and confers a poor prognosis. I highlight this study because it shows how silly the idea is of the smoker's paradox, or the obesity paradox for that matter. Here is the clue, and once I show it to you, I hope you won't be able to unsee it. The papers that purport to show a smoker's paradox have one thing in common. They all look only at patients having a STEMI who had a PCI. Now think of the causal pathways. Okay, smoking causes an MI, so that's an exposure that causes a disease. But age also strongly causes an MI. That's a confounder which also causes the disease. But age also causes death, which is a confounder that causes the outcome. So the study from the Journal of the American Heart Association by Gupta et al. Includes only people who have a STEMI. And so they're conditioning on the collider. STEMI is the collider because multiple causal pathways lead to it. Age leads to it. Other risk factors besides smoking leads to it. So the artificial relationship leading to smokers having lower inpatient mortality stems from the fact that smokers having an MI are younger and less likely to have other risk factors. They often have less complex coronary disease. And conversely, non-smokers who have an MI are surely sicker, older, and have other risk factors that lead to higher mortality. Therefore, when you compare the two outcomes over the short term, you get a false impression where smokers appear to have better outcomes. The evidence for this comes in the fact that the adjustment for simple things like age lessened the risk. The hazard went from 60% better for smokers to 40% better after adjustment just for age. Now, the classic example of collider bias is the so-called birth weight paradox. Among all infants, maternal smoking during pregnancy is associated with an increased infant mortality as expected, but when analyses are restricted to only low birth weight babies, maternal smoking appears to be associated with a decreased infant mortality. Why? Well, maternal smoking causes low birth weight, but congenital abnormalities and other really bad things cause low birth weight. So when you look only at low birth weight babies, you see that maternal smoking seems protective because the non-maternal smokers who have low birth weight babies have much worse problems. Now, the reason why the JACC intervention paper does not show the paradox is mostly likely due to the fact that they use 10-year follow-up as time allows smoking risk to accumulate. So my final comment is, always, my friends, beware of paradoxes where something that you know to be bad, like smoking or obesity, associates with better outcomes. These things don't exist, or at least I have not found one. The most remarkable thing about these paradoxes is how often published papers purport to find them. I searched and found well more than 200 studies for the obesity paradox. It's crazy. It doesn't exist. There was even a smoker's paradox noted for COVID-19 pneumonia, wherein smokers seemed to do better. Of course, this too was collider bias, wherein when you compared only patients with pneumonia, smokers had fewer risk factors for death than non-smokers who had infection. All right, next topic is chronic total occlusion PCI, CTO PCI. The ischemia trial investigators have published in JACC a subanalysis of their trial, the ischemia trial, which was, as you know, an RCT of an invasive versus conservative strategy of patients with moderate to severe ischemia on stress testing. The current subanalysis studied patients with a chronic total occlusion, or CTO. This is an important question because to be a so-called CHIP operator, that's complex, high-risk, indicated procedure operator, one should be able to do a CTO. CTOs are pretty common. Technology has improved and opening these total occlusions is increasingly possible. When I talk to patients about chronic total occlusion, they often have trouble understanding how they are alive with an occluded coronary vessel. Of course, we doctors understand that collaterals often grow and provide blood to that area. The indication to open a chronic total occlusion can be A, symptoms, angina, or B, a large area of ischemia, and both of these phenomena are due to inadequate collateral flow. I also think some doctors doing so might improve ventricular function because you're improving blood flow to a large area of myocardium. But here's the problem with CTO intervention. The evidentiary support for it is not only weak, but I think non-existent. In 2009, a decision CTO trial studied PCI or no PCI of a chronic total occlusion in more than 800 patients. They reported nearly identical rates of MACE, absolutely no difference. 3 patients had serious complications from the procedure. In 2023, the smaller 380-patient trial, 3-year follow-up of the Euro CTO trial of PCI versus OMT, medical therapy of patients with CTO found no significant difference in CV death or MI. And in 2016, even smaller Explore trial of STEMI patients with a non-infarct CTO versus a non-CTO PCI found no difference in LVEF and follow-up. And as for symptomatic improvement from CTO PCI, perhaps the strongest evidence came from the main results of the Euro CTO trial. And in 2018, published in the European Heart Journal, the authors reported that PCI versus medical therapy led to an improvement in angina frequency, quality of life, and physical functioning. However, as you all know from the Orbita trials, unblinded PCI trials that measure subjective measures are fraud. One group gets a big procedure, one group gets tablets. That's not an ideal comparison because of placebo effects. All right, now to the ischemia trial substudy that was in JACC. Turns out about 3,000 of the 5,000 total patients had a CCT available study. Recall that CCTA was used in the ischemia trial to screen for left vein disease and for no coronary disease. Recall also that CCTA is not ideal for identifying total occlusions. Sometimes the CTA shows a total occlusion, but it is a subtotal occlusion, which would make PCI seem better. Now, of these 3,000, nearly half had at least one chronic total occlusion, and 750 in the invasive arm and 718 in the conservative arm. The first data point of interest is that patients with a CTO compared with no CTO, they were sicker. They had higher rates of cardiovascular death or MI and all-cause death. However, in the CTO patients, the invasive versus conservative strategies did not reduce outcomes. For instance, there was no difference in the composite of CV death or MI. There was no difference in CV death, all-cause death. Now, there were more procedural MIs in the invasive arm and more non-procedural MIs in the conservative arm, but total MIs were no difference. One note here is I suspect that a CTO-related peri-procedural MI are more serious than procedural MIs in regular high-grade stenosis. I say this because if you cause an MI from trying to open a CTO, which is chronically totally occluded, you may have harmed another vessel, whereas a procedural MI from a standard lesion could just be a troponin leak from debris. Now, that's a Mandrola theory, but I just suspect that peri-procedural MIs with CTO may be more significant. The authors also did an analysis of the 3,000 patients with available CCTA scans and looked at outcomes based on the presence or absence of a CTO. This is like a subgroup analysis of the main trial. Here, the CTO status had no significant effect on any of the major adverse cardiac event outcomes. Now, the authors then did something very curious. They took the 137 patients who had successful revascularization of a CTO with PCI and 216 with CABG, and they did a Bayesian analysis of outcomes in those who had a successful CTO revascularization. And with absolutely zero surprise, those who had successful CTO revascularization versus the conservative had lower rates of all outcomes. But they did have a higher rate of procedural MI. Now, the probability of difference in all-cause death was low, but CV death was lower, MI was lower, unstable angina was lower. I will talk more about this in the comments, but I want to interject now how problematic such an analysis is. You can't compare only patients who had a good outcome with the invasive approach to the conservative patients. That's not how medical practice works because you don't know before you start if you're going to be successful. What doctors want to know is whether having a CTO makes the invasive arm better than the conservative arm. Now, the authors also did a quality of life assessment, and of course the invasive arm does better when there is a CTO. They also did an analysis of those with a successful revascularization. And again, those patients felt better. My comments. I really think this is an important area to look into, right? Because the presence of a CTO definitely indicates a higher risk patient who has more severe CAD, as evidenced by the higher rates of events in patients who had a CTO versus those that didn't. So it is conceivable that an invasive approach might be better than a conservative approach, but that is not what the authors show. And the fact that an invasive approach did not lower outcomes is similar to all kinds of previous data, like, for instance, the many sub-studies of courage and ischemia, which all found results similar to the main study. That is, that there was no benefit of adding PCI in courage or the invasive arm in ischemia. I would also add that the revived BCIS trial of severe ischemic cardiomyopathy found no benefit of PCI versus medical therapy, which is remarkable because these patients had severe CAD and LV dysfunction. The revived authors have also searched for subgroups of patients with more severe disease who might benefit, and again, they have not found any degree of severity that renders revascularization better. So the findings of this study strengthen the idea that no matter the degree of CAD, absent left main disease, if the CAD is stable, medical therapy initially is the best choice, period. As for CTO PCI, I would not be distracted by the author's emphasis on reduction in spontaneous MI. Why? Because total MIs are not reduced and no other outcomes were reduced with the invasive approach, like CV death, for instance. And surely we should not put much weight looking only at successful CTO procedures. This is a totally unfair comparison because medical care does not have the benefit of knowing the future, and I'm surprised the authors added it. Overall, I remain really worried about CTO procedures. I cannot find a shred of evidence that this invasive, potentially risky, and costly procedure benefits patients in terms of outcomes. But I add the caveat, like many procedures with weak or no evidence, there may be a small set of patients who benefit. But that is where trials come in. You have to show it. Now, there is an ongoing, really big trial now called the ischemia CTO trial, but is not expected to report for 7 more years. Now, imagine how many of these procedures will be done in the interim. The editorialists of this paper tell us that there are 2 ongoing sham-controlled CTO trials, which are super, super relevant because to date, the only evidence to support CTO PCI is quality of life, and we know that if you're going to look at subjective measures, you need a proper sham. Okay, final topic briefly is ACC and ERA Preview. I wrote an ACC column on 5 picks of trials to look at. It's totally biased selection. I looked at Warrior, will study intensive medical therapy for ischemia and no obstructive coronary disease in women, so-called INACOA. It's good on the authors and the NIH for funding such a study. This is what we need more of from the NIH. It's money well spent. I felt like the STRIDE trial of GLP-1 agonist in PAD, peripheral artery disease, is a marketing trial designed to carve out another niche for an expensive drug. I also highlighted my colleague Pavel Osmosanic, who spent years doing the Prague 25 trial, comparing, get this, AF ablation to intensive weight loss. I bet ablation wins, but maybe not. And if weight loss works as well as ablation, oh my, that would be provocative. There's going to be a PROTECT TAVI trial. Will be yet another test for embolic stroke prevention during TAVI. It's going to be a big trial, but I worry that even this trial is likely to be underpowered. And speaking of marketing versus science, the DAPA TAVI trial will compare DAPA to placebo after TAVI. Now, the thing about this trial that makes me think of marketing is you could test the same question for any cardiac procedure, right? Think about it. That is, you could take any cardiac procedure and then add an SGLT2 inhibitor versus placebo after the procedure, and you will likely get fewer heart failure hospitalizations because the SGLT2 drugs are diuretics after all. Now, we'll see what it shows, but it's likely to be driven only by heart failure hospitalizations. And whenever I think of an SGLT2 trial, I'll always wonder if the investigators will tell us about all-cause hospitalizations because heart failure hospitalizations, remember, are only one subset of all total hospitalizations. And then European Heart Rhythm is in Vienna. There'll be lots of news about the hot new kid on the block, PFA. A Swiss-led team was going to report on a PFA versus cryoballoon trial, and I will report after the trial all that I learn about PFA. I actually have to give a contra-debate arguing against PFA. But I have not done a thermal AF ablation in like 8 months. I am a PFA evangelist, but I still think I can put together a lecture on why we need to be careful with any new AF technology. And finally, I'll close the podcast by saying, please, ACC and ERA people, will you get together, have some coffee, and figure out how to get these meetings on different weeks so we can go to both. So that's it for this week in cardiology. Next week and the following weeks, I'll have a review of many studies. And remember, if you like this podcast, please take the time, write us a review. If you disagree with something, leave a comment. This week, we had a beautiful comment. It led me to a very interesting study, so thank you. Until next week, when This Week in Cardiology broadcast from Europe, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.